traumatic brain injury.
Hold on a second. Good morning, everybody. We're back. Dr. Morgan here with us, and I'm going to hand over the microphone to him, and here's his slide. So good to go, Doc. All yours.
I don't need to hold that, do
You,
I?
you do not.
Okay,
You
good.
can if you like, but you do not
No.
need to.
Can they hear me? Everybody hear me okay?
There's a whole lot of responses, so yeah.
Okay, that they can hear, okay, gotcha. So we're gonna talk about traumatic brain injury. I gave this lecture last month
Yeah.
at the PHCLS course and stuff, and so it's pretty much the same lecture. But a lot of new stuff, I mean, at least from when I was in the field decades ago, I mean, there's been some new stuff about traumatic brain injury. Back in the old days, you couldn't do anything for them. You just transport them and hope for the best. But now there's actually a lot of things that you guys can do to help with some of these things when you pick up these patients. Okay, everybody knows these guys. Let me see if the video works. No?
May have to go to the mouse on the computer there and hit the play. So it has one.
I don't
That was in the
want
bottom left.
Where's the?
Sound? What happened to?
There you go. Oh, now it's off.
I don't know. Why don't you just change that?
Way to tear it up, Dr. Morgan. Can't have nice things around here.
Don't worry about it. We'll move on.
Computer is
It
where
was
the
just
sound's
a,
going
just
to.
a 30-second
Speakers on?
thing. I thought it was funny. I found that last night. Okay, you took me off here.
You have to let it play now.
This worked better when we had my phone.
I know, well, trying to stream it out, so it creates a little tiny.
All right, well, you can pull that up when look at it later.
Okay. I bet they block it anyway.
Do what?
They'll probably block that one anyway. YouTube will block it.
Probably right. Oh, it played fine for me.
We're rebroadcasting another YouTube channel, so they'll block it.
Oh, I see what you're saying. Okay.
There you go. Can you hit next over there for me? Or hit the exit button.
Dear God.
Got to get back to the PowerPoint.
You know, we got some traumatic brain injuries in this room.
Bring that. Well, we went to YouTube.
Technology, huh?
Yeah.
Must be Smith.
Close out of that. Left,
You can reload it.
left keynote and went to YouTube.
What's that? Was it in?
It left keynote and went
Up
to
there at the
YouTube,
top.
so we just gotta go
No,
back
no,
to
no.
it.
Oh, there it is.
Great guru movie.
For some reason.
Okay, well, that was a
A little
nightmare.
bit of work.
Everybody hang on, we're having fun in here.
Play. There you go.
Just need to skip the YouTube video.
There we go. Okay.
Full screen.
Woo!
Yeah.
That was a mess.
Goody.
So it's interesting that the brain is the most important in the body, and that's according to the brain itself. I find that interesting that it thinks that. I wonder what the heart thinks about that. I think that's probably more important. So to discuss a little bit about anatomy, when we start talking about brain injuries and what you're going to find in the field when you start assessing these people. You have to kind of understand a little bit about the physiology and the anatomy of the brain. Here we have the lobes of the brain: the frontal, the temporal, the parietal, and the occipital lobes. The frontal lobe is you guys, and I'll show you a little bit of a case of a guy that got impaled. You probably have heard about that case, but that is where your personality lies, in that frontal lobe. And whenever somebody conks their head, interestingly, my mother-in-law had this. She fell in my yard several years ago, and she just kept repeating herself and was inappropriately laughing and crying almost at the same time, and that's from hitting her frontal lobe. and contusing our frontal lobe, and that's what you'll see with those patients that have brain injury. Parietal lobe is where all of our sensory centers are. It also participates in speech along with the back part of the frontal lobe. When you start talking about speech, if they hit the left side of the head where we call Broca's area, that's the speech center, and that's why you get people who have issues with strokes that involve the left side of their brain. They'll have speech difficulties when that occurs. The temporal lobes involve processing and consciousness, and the occipital lobes are where the visual centers are. When we talk about the meninges, this is where the bleeding occurs, and you can see there's the 3 layers up there on the top left of the screen, the dura mater, the arachnoid, and the pia mater. So those layers are all adhered to one another, but you have blood vessels that course between each one of those layers, very small. And that's where you see a lot of bleeding episodes. You've all heard of the subdural hematoma, which lies above the arachnoid and below the dura mater. That's the venous bleeding that occurs very slowly. Then you can get the epidural that's on top of everything, and that causes the rapid bleeding after a period of lucidity. And I'll tell you about a case of that here in just a little bit. And then you get the subarachnoid bleeding. That's where they conk their head and they start bleeding, oozing, and on the CAT scan you see this star-shaped pattern of the blood leaking out. And a lot of those can be hypertensive bleeds as well. So the physiology, the brain requires oxygen, glucose, venous drainage. That's why we have you elevate their head a little bit. The nutrients that's carried by the CSF, an adequate blood pressure, and an intact blood-brain barrier. That's where some drugs get through to the brain and other drugs don't get through to the brain. But it requires all these things working together in order to keep a person, when they leave the hospital, the same as before they had their initial accident. The Monro-Kelly doctrine, I don't know if you've heard of this or not, but this is kind of an important concept. The skull is a fixed container with the brain, the CSF, and the blood volume within that fixed container. And anytime there's an injury to the brain and you get an increase in one of those components, or even 2 of those components, something else has to suffer. So if you get a brain that's swelling, it's going to put pressure on the blood vessels and the CSF, and you're going to have a decreased cerebral perfusion pressure, and you're not going to get as much oxygen to the brain. Likewise, if you get bleeding inside the skull, it's going to take up more real estate, and it's going to put pressure on the brain and the CSF. And so something's going to suffer. Every time you have an increase in one of these components, you're going to get a decrease in the other 2 that's going to cause a compromise to the whole CSF system, or the whole cerebral system. So the Monro-Kelly doctrine. Brain hemodynamics, this is what we look at when we have patients in the ER and go into the ICU. And this is why what you guys do is important, because this is what we're trying to preserve. The cerebral perfusion pressure is that difference between the mean arterial pressure and the ICP. So if you get an increase in one, you need an increase in the other one in order to maintain the same perfusion pressure. Likewise, if you get a decrease in one, you've got to have something happen to the other side of the equation to keep that perfusion pressure normal. That's why they put those ventricular catheters in the ICU to drain CSF. So if the ICP gets too high, they can only get the map up so high. They've got to drain some of that CSF down to decrease the ICP so they can keep that map down to a reasonable level. But many times in the ICU, you'll see them trying to keep the pressure, the blood pressure on the high side so they can keep that perfusion pressure up. And there's the normal numbers, nothing you're going to measure in the ambulance itself, but it kind of gives you an idea of how much difference there are between 60 and having a normal ICP of 7. Okay, I have to put up all my shimmers here. I don't know why it's sticking, Kyle. Okay. Primary injury is that injury that you really can't do anything about. That's the initial injury that the patient suffers. It's the secondary injury, or the potential for a secondary injury, is where you guys can make a big difference in what you do for that patient until you can get them to the hospital. So you have to think about everything that's going to happen after that initial injury when that happens. So we're all about the secondary injury. Here's your types of traumatic brain injury: blunt trauma and penetrating, and all these different kinds of blunt trauma. Those are the primary ones you're going to see. You're not going to see very many true penetrating injuries. Most of ours are going to have to do with blunt trauma, whether it's a football player on the field of play and he gets a concussion, to somebody who's in a rapid deceleration accident and they're going to end up with diffuse swelling in their head and end up with a diffuse axonal injury to where they'll probably never recover unless they get really lucky on some of their good ICU care and things like that. The hemorrhages, depending on the kind of hemorrhage, how much there is, and whether or not they're going to get surgery, will make a difference in that. But a lot of things that you guys do can keep them headed in the right direction after they arrive to the ER. I don't know if you guys have ever heard of this guy, but you can go to Wikipedia. It's a pretty interesting case from the early 1800s. This is a penetrating traumatic brain injury, and this guy lived after this. Jeff, have you heard of this guy?
Mm-hmm.
He ended up dying in his 30s from status epilepticus. But that tamping rod penetrated through and destroyed a lot of his frontal lobe. And he was a calm guy. He was a foreman on a railroad crew, and he was like an upstanding family man. And after this injury, and after recovered from the initial injury, he became like a loudmouth, kind of like a, they couldn't control him. He was quick to temper, and there was a definite change in his level of personality, and that's that frontal lobe I was telling you about. So it's kind of an interesting read if you go to Wikipedia and read about this guy, how the rest of his life went.
Ripley's Believe It or Not too, I believe he was on there.
Was it? Yeah. His skull is actually, his actual skull is actually in the museum at Harvard Medical School. Okay, brain hemorrhage. We start talking about the brain hemorrhage here, the different layers that we talked about. Up there in the top left is the epidural hematoma. The bottom left is subarachnoid. That's the hypertensive and the blunt trauma that goes right underneath the arachnoid layer of the meninges. The subdural are the ones that you see the drunks have, and they'll be kind of down for a while, and when they get to the ER, they get CT, they may see chronic subdural with an acute subdural in the same layer of the meninges just over the dura mater. And it causes a slow decline in their level of alertness. And then the intracerebral hemorrhage, those are the ones that are either tumor-based or they're hypertensive. The one in the upper left, I've told people before, is an actual case of mine, the epidural hematoma. What happened was this little boy, he was 11 years old, had been at his mom's office and playing around on a rolling stool in her office, and he fell off the stool and hit his head. Wasn't acting right, but otherwise he didn't lose consciousness or anything like that. Mom called grandma to come pick him up and take him home with her, with his two siblings. He continued to have difficulties at grandma's house, and she brought him into the urgent care. And so when he comes in to see me, he's kind of laughing inappropriately, but not too terrible. I mean, just a kid, kind of a makeup as far as his personality was concerned. And I couldn't really see much in the way of a bump or anything on his head. But his grandma said he just wasn't acting right. So I did all the neuro tests in the urgent care, checked his pupils, everything. I mean, he had nothing. The only way I determined that he had something going on is I had him get him up and walking. Okay, and that was the one that helped me determine what was going on. I got him up and walked him across the room, and he about fell over. touched the doorknob, and he came back and he about fell over again. So I told Grandma, he's got to go to the hospital. He needs a CT scan. He can't walk. He's ataxic. So she took him there, and that's what they found. Matter of fact, Matt Grounds sent me a picture of the CT. That's how I got that picture. And I think they transferred him either to Kansas City or Springfield. I can't remember. I would suspect, and I never did hear the follow-up, but I would suspect that he did okay, because those, you just got to evacuate them, get the pressure off the brain and stuff. But the epidural is interesting, and that's where they hit their head, and you know, you'll roll up on scene and they'll be fine. They'll say, oh, I'm fine, I feel fine. And then 20 minutes later, 30 minutes later, you get another call, and you find out that, okay, he's gone down, there's something going on here. They have a period of lucidity before they get this downplay in their activity level and their level of alertness. And that's a pretty well documented hallmark of epidural hemorrhage, is that period of lucidity before they go downhill. The rest of them, they kind of steadily go downhill from the initial injury, but that epidural, it just takes time to accumulate to start causing that change in the way they present themselves. We all know the signs and symptoms of TBI: changes in level of consciousness, headaches, the pupillary changes we'll talk about, seizures obviously. We'll talk about Cushing's triad here in a minute. Vomiting is a big one, nausea and vomiting. If it's a little kid and they're nauseated, I don't get too concerned about it. Most kids have some period or some evidence of nausea and even vomiting. When an adult does it, that gets my attention, and those patients always get CT'd. They get a change in their speech pattern, whether it's an aphasia where they just don't want to speak, or whether it's very slurred, or in their manner of speaking, they can't find the words that they want to say, and they'll say things inappropriately, and they'll laugh knowing that they're saying the wrong thing. They just can't think of the right word to say. Infants, bulging fontanelles, cranial suture separation. That high-pitched cry is truly a thing when they get that, when they get an increased level of swelling in their head. They'll get that high-pitched cry. A lot of babies, when they get this, they don't want to be held. They'll cry worse when they're held and coddled, unlike a normal child. As opposed to when they're laying down. They prefer to lay very still, and they're not near as demonstrative in their emotions and their crying as they are when they're held and moved around. Cushing's triad, or Cushing's response, is a physiological response where you see an increase in the blood pressure and a decrease in the heart rate, and especially if you see those actively changing. That's why repeated vital signs are very important. You also see an irregular breathing pattern in a lot of these patients. It won't be anything like a Cheyne-Stokes usually, where you can sort of get the pattern down. It'll just be very irregular when they do that. And most of the time it's a lowered respiratory rate rather than a raised respiratory rate. Nowadays, almost every other patient you guys pick up is on a beta blocker, so that's even less helpful. When you see a lower heart rate, you can't always determine that that's truly due to the Cushing's response, because it could just be their medications causing that. And everybody's blood pressure goes up when they're in pain, or they're having difficulties, or they're anxious or scared. So it's just one of those things when you see it, especially if you see somebody who has this response and they have a decreased level of alertness, that's more than likely what's going on. If they're awake and talking to you, otherwise looking fine, then it's probably more fright and scared, anxiety, and maybe they're beta blockers that may be causing these changes in vital signs. But it's something you need to be aware of, and that's why, again, repeated vital signs are very important. Assessing these patients, you definitely want to get an oxygen saturation. You're going to do all this anyway. A blood pressure. You're going to calculate the Glasgow Coma score, just so you have an initial one to give to the ER people, and they're going to follow that. And the neurosurgeons use that. They use it in surgery, before the surgery. They use it or before they go in, or anesthesia. They use it in the ICU along with some other scores. that they're gonna be calculating, but that's important to know in an initial Glasgow Coma score. And then checking their pupils, the size, whether they're asymmetric. You've all heard of anisocoria, that's a slight decrease in that's a slight irregularity in the size of the pupils, but both pupils will almost always respond to direct light. And sometimes we'll see patients like that hit their head and they'll have just a little bit of difference in their pupillary diameter. And so we'll take their driver's license and look at it with our ophthalmoscope under the microphone and look and see if we see that in the picture on their driver's license as well, so we can kind of document whether or not, okay, they had that on the driver's license photo, it's probably just them. When you see something like that, that is definitely going to be irregular. That's an oculomotor nerve issue, especially on that right pupil over there, and that's going to either be from some injury to the optic nerve, not the optic nerve, the oculomotor nerve, the cranial nerve number 3, or it's going to be something causing an increase in pressure within the brain itself. You guys all know the Glasgow Coma score, eyes, verbal, and motor. Speech, definitely going to see how they're talking. Movement, if you get to the scene and they are not like, you know, in a car, you have to extricate them or anything like that to where you have to worry about selective spinal immobilization or anything, and they're up moving around. Watch how they're walking, very important. Dr. Greg Henry is an ER doctor. He's retired now in Michigan, and he lectures on a lot of neuro injuries, neuro complaints, and he says, look in their eyes, hear them talk, watch them walk. Those are his 3 main things that everybody should do that assessing emergent patients. Look in their eyes, hear them talk, and watch them walk. You're going to pick up a lot of neuro problems just by watching those things. External signs of head trauma, periorbital ecchymoses, otherwise known as what? Raccoon's eyes. Battle sign, hemotympanum, if you are lucky enough to be able to look in the eardrum and see that bleeding behind the eardrum, that tells you that there could very well be a basilar skull fracture. Here's another indication of battle sign. And you can see that it's blood tracking from a basilar skull fracture when they get that, and it causes the same thing as far as the raccoon's eyes. It's just blood pooling from a fracture, because there's a lot of blood vessels, a lot of capillaries down there around the base of the skull, and it will definitely cause these signs. And it's not a direct trauma to that mastoid process, it's actually blood tracking from the basilar skull fracture. Okay, now we get into the meat of the thing here, talking about the EPIC trial and the things you guys can do in the field for these head trauma patients. Excellence in pre-hospital injury care was a big project done in Arizona. It involved, I think, 130 plus EMS agencies, several hospitals. Who would think there was 130 EMS agencies in Arizona? But I guess there is, if you include the Indians and all that. But this was from like 2007 to 2019, and they looked at over 21,000 patients. And they watched how the paramedics cared for these patients and the ultimate outcome of these patients, and what happened to the patients as far as vital signs and O2 saturations and end-tidal CO2s and things like that. And they came to some very definite conclusions about how paramedics should be taking care of these head injury patients. And they categorized them into moderate, severe, and critical. And you can actually go online to the Brain Trauma Foundation and read these pre-hospital guidelines for the management of traumatic brain injury. This has been sanctioned by the American College of Emergency Physicians and the trauma doctors, the surgeons, and almost every big organization out there that has to do with trauma patients. This study has been sanctioned by them as far as very good information when you're taking care of trauma patients with traumatic brain injuries. And you can find this online. It's a pretty detailed paper, but it's got some good information in it that talks about this. So these are the 3 H bombs that they found with all of this 21,000 plus head injury patient roster is three things that will really get your patient down and cause them to die: hypoxia, hyperventilation, and hypotension. The three things you guys need to watch for in these traumatic brain injury patients. So we're going to talk about each one of these. Hypoxia, the brain, as we talked about, requires a continuous supply of oxygen and glucose. Even a single episode of hypoxia can increase the morbidity and mortality of the traumatic brain injury patient. And that's after looking at all these. And we're talking about O2 saturations of 90, you need to keep above 90%. So every TBI patient, whether they have lung issues or anything like that, needs extra oxygen. You should always put them on oxygen. Even one episode of hypoxia doubled the likelihood of mortality in all these patients they looked at. You think about that, okay, well, why would a patient have hypoxia from just an isolated head injury? Decreased level of alertness, body habitus. Their chin's gonna go forward. You're not monitoring them closely or not. They're gonna be hypoventilating, okay? They're gonna be slowing down. Could be something to do with Cushing's triad, and their O2 sat will drop down. You know, in a COPD patient, when it drops down to 86, they probably live there, and you're used to that. And we just bump them up their oxygen a little bit, give them a breathing treatment. In a head injury patient, in all these patients studied, even one episode doubled their mortality. Think about that. I mean, if you don't watch that oxygen level, you can double the chance that your patient's gonna die and not recover, especially in the severe and the critical categories. The moderate, not so much, but the severe and critical, and that has to do with parameters of what the ultimate injury was, what their initial vital signs were, and the level of time prior to EMS response or prior to EMS arrival on a lot of these patients. But you definitely want to make sure that even if their O2 sat is 98% when you get there, they all need supplemental oxygen. You want to guard against that. We're not worried about extra oxygen in these patients. Definitely want to assess the respiratory rate and depth. You're trying to determine which patients may be at a risk to decrease their respiratory rate and their oxygen saturation, so you want to sort of be on guard for that. All TBI patients need high flow oxygen. They need a non-rebreather, not a nasal cannula. They need a non-rebreather. If you see escalating signs of hypoxia, their O2 sat starts dropping, reposition their airway, keeping in mind their spine. You may want to elevate the head of the cot, or if you do have them on a backboard for selective spinal mobilization, you may want to make sure their head's elevated. Bagging them with a bag valve mask has been shown to be the #1 thing that they recommended after this study. Not so much intubation, but just bagging them if you need to get them bridged until you get them to the hospital. You can consider use of a subglottic airway or intubation, but if you will just gently reposition their jaw and their airway and provide that supplemental oxygen, the vast majority of people will respond to that. If you have to consider intubating a head injury patient, you have to consider, is the risk of even dropping their O2 sat one time or hypotension worth the benefit of that? Most patients you shouldn't need to intubate. Now, if you have a prolonged transport, or it's been a prolonged extrication, or they're vomiting profusely, yeah, you gotta make that choice. It's a choice you have to make. But it's really gonna be a hard call on your part to suffer with that, because, you know, as we all know, all of us, as we intubate, many times our O2 saturations are gonna drop down, depending on how quickly it takes us to get that tube in. So you have to be aware of that, what you're doing for your patient. The next thing is hyperventilation. You want to avoid that. Now, some patients, like I said, I told you that some head injury patients will slow down their respirations, but many times they'll have something like Biot's respirations, or to where they're increasing their respiratory rate. Or if you have to supplement them with a bag valve mask, you want to do it carefully. You don't want to hyperventilate those patients. Increased PCO2 causes vasodilation and increases the ICP, but a decreased PCO2 will cause vasoconstriction, where you get a decreased oxygen delivery, and it's the same as causing hypoxia. So you gotta maintain that medium level of their O2 when you're doing that. You wanna maintain them between 35 and 45, like you do almost every patient. You know, the entitled CO2 is 40, so we wanna keep it as close to that as we possibly can. You don't wanna excessively hyperventilate those patients. Now, if you get signs of herniation, okay, to where you get a big dilated pupil and they're vomiting, something like that, okay, you may have an expanding lesion within the cranium. And as we talked about with Monroe Kelly doctrine, something's gotta give if they have that brain swelling and you're starting to see signs of herniation. You may have to gently hyperventilate them down, okay? There's no two ways about it. You gotta pick the lesser of the two evils. So you definitely wanna give them a little bit more oxygen at the expense of trying to keep them from hyperventilating. It's not an easy choice a lot of times in those patients. Fortunately, hopefully you get them to the hospital quicker. All right, and hypotension, even one episode of hypotension can increase the morbidity and mortality. I don't have it on the slide, but I believe it tripled their chances of dying. If you get both of these, you get a chance of dying. That TBI seems to be the exception to permissive hypotension. You know, there for a while, if they're bleeding internally, we like to keep their pressure down a little bit until they clot. You get the stop the clot kind of thing that they used to preach about. But we want TBI is the exception to that. So if they have a primary head injury, you want to make sure that you keep that pressure up. Aliquots of isotonic saline, lactated Ringer's is fine. And again, like I said, it's risky business, the decision to intubate versus effects of hypoxia and hypotension. So here's your bullet points. Mitigate secondary injury. That's by doing all the things that we just talked about. Watching their O2 saturation, watching their PCO2 or their entitled CO2 to keep it reasonable, and maintaining a systolic blood pressure of at least 110 if you can. Remember, you keep that map up, okay, and you're keeping that as that ICP goes up from whatever injury is going on, whether it's brain swelling or whether you have intracerebral hemorrhage that's increasing your ICP. You keep that map up a little bit so you keep that cerebral perfusion pressure maintained, keep that oxygen going. Maintain euthermia, basically means keep their body temperature as steady as you can. If it's cold, warm them. If it's warm outside, try and cool them a little bit. Slightly elevate the head to promote venous drainage. Observe spinal precautions as we talked about, and I've lectured multiple times on selective spinal immobilization that we seem to be going to in EMS nowadays. Look for other injuries. Obviously, you're going to be looking for the intra-abdominal hemorrhage. If they have severe back pain, they may have a retroperitoneal bleed. Watch that blood pressure. It's going to be very important when it comes to taking care of people with head injury. And then transport to the most appropriate facility. That's all I have. Any questions?
Yeah, we're about 30 seconds to a minute behind.
Yeah,
So,
20, 30 seconds behind.
yeah.
Behind what?
The streaming audience is a little
Oh,
bit
I
behind
see.
on real time. So
Gotcha.
now that you finish that, they're gonna not know that you said that for about 20 more seconds. Any questions from in the room? I mean, you all heard it live, right? So
I think they've heard this before. All right.
yeah, I still haven't gotten any response on their comments, but we'll see.
They're still sleeping.
They're still sleeping. Wake up, people.
There's a big turnout. Oh, there they are.
Yeah, there's quite a few.
No questions. Thanks, Dr. Morgan.
Okay.
That's what I'm getting.
Sweet.
Yep.
All right, guys.